The pterional approach is a workhorse in neurosurgery. It provides access to most of the intracranial pathology, but it places the frontal and temporal region at risk. This is the temporalis branch of the facial nerve. If you injure this branch here, the patient will notice it forever. Injury to the temporalis branch of the facial nerve is often avoidable. Some flaps protect the nerve, but at the cost of anterior retraction of the temporalis muscle, and that limits the anterolateral corridor. Ideally, if the temporalis muscle is retracted downward, we can maximize the exposure of the anterolateral skull base through a pterional approach. However, the frontalis branch of the facial nerve must be first identified and mobilized to avoid injury during muscle mobilization. Today, without edits, I will show you how to perform the interfascial temporalis dissection, with practical tips to keep it fast, smooth, and safe. The temporalis muscle is covered by the temporalis fascia, which splits into a superficial and deep layer as it approaches the zygomatic arch and the orbital rim. The temporalis branch of the facial nerve runs within the interfascial plane, within this fat pad, between these two facial layers. This separation between the superficial and deep temporalis fascia occurs approximately 2 to 3 centimeters proximal to the orbital rim. Later you will see why this distance matters. Staying in these planes, therefore, allows preservation of the nerve while maintaining adequate surgical exposure. The basin is positioned supine, with the head in a slight rotation to the left side. The skin is inside with a number 10 blade, taking care to preserve the temporalis fascia and the periosteum. Dissection at this stage is carried down over the temporoparietal fascia. In this areolar tissue, we are going to encounter the frontalis branch of the superficial temporal artery that is going to be coagulated and divided to allow anterior retraction. Now, flap needs to be advanced in its temporal region and also in its frontal region. In the temporal region, the scalp is retracted anteriorly until the orbital ring can be palpated. The superficial temporalis fascia and the fat pad are incised vertically, approximately 2 centimeters behind the orbital ring, probably at the same level in which some epiphyseal fat can be encountered in many specimens. This distance is usually sufficient to identify the fat pad and preserve the temporalis branch of the facial nerve contained within the fascial flap. Small violation of the deep temporalis fascia occur in this case, but ideally I should be able to preserve intact for a clean dissection. Almost invariably, the interfascial vein running in this space is violated. And remember, if venous bleeding is not encountered, you are likely not in the interfascial plane. Direct coagulation or gentle pressure is usually sufficient for hemostasis. Indiscriminate coagulation of the interfascial flap should be avoided as it may injure the temporalis branch of the facial nerve. Remind to keep 2 cm distance with the orbit when dividing the superficial temporalis fascia. Now the Penfield number 1 and 15 blade is all we need. We use Penfield to dissect the periosteum from posterior to anterior, and we continue subperiosteal dissection above the superior temporal line towards the orbital ring and the zygoma. Then at some point around the frontozygomatic sutures, subperiosteal dissection gets more difficult. So all we have to do is incising again the periosteum over the posterior border of the frontalis process of the zygoma and continue our subperiosteal dissection from superior to inferior and from posterior to anterior. Now I use 2/0 silk stitches and rubber band to apply continuous retraction to the flap. An important piece of advice is to avoid continuous manipulation of the flap with the sharp edge of the suction or forceps, as this can cause unnecessary trauma. For this reason, elastic retraction is helpful as it provides a stable exposure while minimizing mechanical injury. As we mentioned before, the periosteum is especially adherent over the zygoma. So as we move on, I use sharp dissection or monopolar over the flat surface of the frontalis process of the zygoma, away from the flap to complete the subperiosteal dissection. And I continue all this maneuver until I expose the orbital rim, at least until the zygomatic suture inferiorly. Now I use the monopolar to detach the temporalis from the superior temporal line and the frontal process of the zygoma. Once the muscle is detached, I traction the muscle downward and I do so periosteal dissection with pencil number 1, following the movement you are seeing right now on screen. 4 things are important here. First, remain subperiosteally. 2. Avoid traction from muscle fibers. Always grab pericranial or fascia. Avoid sharp surfaces. Use irrigation for cleansing of the blood that gets into the field. Minimize, use the monopolar. It is difficult to get to the most anterior aspect of the temporalis muscle with pencil. So what I do here is I place a wet retract under the temporalis and I rub the deep aspect of the retract towards the bone so I indirectly complete the superiosteal dissection all the way to the inferior orbital fissure. Please pay attention to the rotation movement that I applied to the retract. Finally, I always use the same 3 to 4 points of fixation for traction of temporalis muscle. First two are superficial, one to the posterior corner and another one to the anterior corner. Grab the whole thickness of the muscle, fascia and pericranium to avoid muscle laceration, and traction it down. See how despite traction we are not using the full potential of the exposure, so we place 2 additional deep stitches through the whole thickness of the muscle as far down as it can be reached. This provides additional 2 cm closer to the floor of the middle fossa. It's important to note that if the stitch doesn't include the full thickness of the muscle, it may shear through the fibers, leading to muscle injury and potential laceration. Finally, a pterional or mini-pterional can be performed as you prefer. I hope you find this material useful and some of these tricks and tenets can be used in your future practice. Give me a thumbs up if you like this video. Thanks for watching till the end and follow up for more.